Hello, and welcome to another of our digital slide reviews and sign-out sessions. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy. The DAPA is a joint venture between the Digital Pathology Association and Path Presenter, which have made this teaching tool possible, and which I've enjoyed sharing with you as our listeners and viewers. We're going to talk today about a rather mundane issue, but something that's a not insignificant problem at times in GYN pathology. So the patient's a premenopausal 45-year-old woman, but someone who's had a variety of abnormal uterine bleeding symptoms over the past several months. So she comes to the attention of her gynecologist for evaluation, and not surprisingly, they do some history and evaluation and testing to consider the various possibilities. And among those sorts of things that one would expect would be hormonal problems, luteal phase defects, those sorts of things. Pregnancy, of course, she's a test that she's not pregnant. And then there are the anatomic or morphological issues, polyps, precursor hyperplasias, malignancy, and so forth. And then much less frequently, infectious or other causes that may be the source. So in her case, having excluded the obvious problems, biopsy ensued, and we get a nice Pipelle type of biopsy of the endometrium with a bunch of admixed blood and some mucus, as you can see here. And at low magnification, this looks like morphologically fairly intact endomyometrium. We do have maybe a few more bluish areas here in one section here. And the glands are small, they're not secretory. And so they might look a little bit like proliferative phase glands. But as we look, we notice that there's a few areas of fibrin, a few little fibrin type clots and so forth. And looking over these glands, we don't really see much evidence of very vigorous mitotic activity. So that's one of my personal clues in looking at things to begin to think about the possibility of endometritis, for example. If I find that the endometrium is difficult to date, in other words, it's difficult to assign whether it's secretory or proliferative, it doesn't look right for either one, and she's premenopausal, then I'll begin to think about that. But there are some caveats, and stromal breakdown, proliferation, dysfunctional bleeding due to hormonal issues can still be a possibility in this situation. So I'm going to just jump to one of the other features that I find useful at times in this is identifying stromal pigmentation, which you can see here in several of the macrophages. And that's sometimes an indication that there's been an altered cycle. In the stroma, we may find some sort of plasmacytoid cells, and distinguishing endometrial stromal cells from true plasma cells is sometimes quite difficult. And I've made that a little bit more so with a limit on the magnification here in this sample of being only 20x. Because oftentimes you need to go to high magnification 40x to really be sure that you're dealing with a plasma cell. Sometimes we think of lymphoid aggregates as maybe being an indicator of potentially chronic endometritis, but this actually is rarely true. Lymphoid aggregates are uncommon, and they don't really have the significance of chronic endometritis. Sometimes they're present very innocuously, but they're very uncommon in general. But they can be one of those features that leads us to suggest the possibility and the need to look carefully for plasma cells. We found one here, which is a little bit plasmacytoid there. And the other feature that I think may be helpful sometimes is sort of finding this little cuff of lymphocytic cells around the glands. just indicating that there's something immunologically going on. But as you've noticed here, I have not identified any classic plasmacytic features in this lesion, despite showing you multiple high power fields and looking at this for quite some time. So is this endometritis? Well, if I find enough of these soft features, I will then resort to doing a stain, an immunohistochemical stain, to verify whether or not there are plasma cells present. And so that is what I indeed did in this case. If, on the other hand, I find plasma cells relatively easily and they seem quite classic, the immunohistochemical stain is not necessary. It is a little bit helpful in terms of finding the rare events that we associate with that. Now, we won't concentrate on the control tissue there on the left, part of which is fragmented over here, but I'll point out that endometrial glands will stain with CD138. So this stain is not entirely specific for plasma cells. It will sometimes stain endometrial cells, as you can see here. But what we're looking for is isolated cells in the stroma. And with this kind of a background, these cells tend to jump out at us. You'd like to see strong cytoplasmic staining with maybe a little clearing where the nucleus ought to be. And they're generally disposed as single cells in the stroma, as you can see here. Occasionally, you might get a binucleate form. So in this particular case, we have several such cells which on high magnification certainly fit the bill for plasma cells. And in this setting, this stain is virtually diagnostic of chronic endometritis. Well, what's going on with chronic endometritis? Well, essentially, it's defined by the presence of plasma cells within the endometrial stroma. And it does have some clinical association with infertility or recurrent fetal loss, although in our patient, we doubt that she was trying to get pregnant and had other symptoms, just abnormal bleeding. There are a variety of organisms that can be associated with this. They tend to be things like strep or E. coli, enterococci, and so forth. And as I've indicated, a cytoplasmic CD138 stain is useful. MUM1 can also be useful in confirming the presence of plasma cells in this environment. Now, what are the caveats? Well, there are times when I might soften my diagnosis from chronic endometritis, next case, to something like consistent with or suggestive of, and that's in the setting where I have evidence of breakdown, sort of a premenstrual type of thing, or when I have some sort of a mass lesion like a polyp or leiomyoma that may be associated with that, or in the setting of where there's been an IUD in place, which is part of the mechanisms of IUDs preventing pregnancy, is to create an inhospitable environment. So let's look at a few more cases just to help to illustrate some of the spectrum of disease. Here we see, again, sort of non-secretory type glands, but there is a little bit of secretion, and they are a little bit longer and so forth. We look at the stroma here, and things don't jump out at us. Now, I indicated that sometimes I use the non-proliferation or non-secretion status as helpful. I think there are cases where actually finding epithelial mitoses, such as you can see here, should not prevent you from thinking about that if you have other features, such as abnormal bleeding and so forth. Now, again, in this particular case, we have some suggestion that there's early fibrin thrombi in some of the superficial vessels. Here we see a little bit of sort of syncytial and breakdown changes with stromal condensation and balls of endometrial cells, which we often think of as a menstrual finding. And then we also have some endocervical tissue here, which you can see here is characterized by the endocervical type epithelium. So we ended up doing a CD138. Oh, let me just, before we go, let me see if there's any other. No, I think those were the two things I wanted to show here. So let's take a look at the immunohistochemistry stain. Oh, I guess I didn't have that for this case. So in that case, there were some immunohistochemical stains that were positive, but they seemed to be more associated with the endocervical epithelium rather than the endometrial tissue. So that's another caveat to be aware of. Well, here's another case, maybe a little bit more atrophic appearing or inactive appearing tissue. And this illustrates another challenge. So here we again see these little hemorrhages and microthrombi here, sort of features here. We don't have the same degree of surface breakdown change that we might associate with this change. And in fact, in these areas under my microscope, there were several cells that looked to me like they might be plasma cells. In addition, I also identified occasional eosinophils. I think you can see one here. And so eosinophilic endomyometritis can also be associated with chronic endometritis or the infectious versions of this lesion. So here's a immunohistochemical stain from this particular case. And as we look around, we see there are not very many here. They're not jumping out at us from this stroma here. And so many broad areas of this are free. But then occasionally we'll find an area like this, where here we've got one. And this, I think, is the value because of this stain, because it can be a real time saver. You can hunt and hunt and hunt for a long time, multiple levels, looking for plasma cells in a suspect case and not find them, and then do a CD138 stain and find them literally within seconds or minutes, rather than decades or centuries sort of thing. So again, that illustrates the value of the stain. Another example, relatively scant sample here. And again, we see a few small fragments here. In this particular case, we also had rather thick sections. So thick sectioning can make it very difficult to identify plasma cells at times if your staining is not real crisp. And so when I look at an area like this, it's kind of thick. It's really hard to pick out the plasma cells, or maybe one there, or maybe another one up here. The other feature here, however, which raised interest was this little structure here looked very much like it could be an epithelioid granuloma. Clusters of histiocytes, a lot of pink cytoplasm. And so sometimes plasma cells can go along with other types of endometritis as well. However, in this case, again, we have these little areas of stromal breakdown. And that's what, again, you wonder about that sort of premenstrual change, especially if you get very much of that and very much of the syncytial changes, because that's kind of how the process proceeds when patients begin to slough their endometrium. Here we'll look at the CD138 for this case again. And I think you can see here we have quite a few clusters of nice single cells, a little bit of a clustering in some areas here, and a little bit of dirt on the slide as well. But I think you'll be satisfied that those are plasma cells or positive staining cells. One final example, this one I think are a little bit more abundant tissue. And in this case, as we look at this tissue, we actually begin to see another picture. So all the previous ones have been kind of proliferative-ish. This one looks much more like secretory endometrium and has, kind of complex glands. You're beginning to see some predecidua around these vessels that would indicate that there's a normal cycle going on and that this may be approaching the time of menses, because as you get that predecidua, then you'll soon begin to detect inflammatory cells in the epithelium, in the stroma, that will begin to cause that breakdown. And if in this situation you find plasma cells, I'd be very cautious about interpreting it as chronic endometritis, because it may be much more likely to be physiologic or quasi-physiologic in this circumstance. So this is one of the caveats here. And indeed, when we do a CD138, we don't see very much, but fortunately my colleague was able to identify a couple of single individual cells. So in this case, I would say this is possible or suggestive of, but I would not be flat-footed. This is absolutely surely chronic endometritis. I would say more likely suggestive of, because in this situation, we've had a hormonal cycle, and it would be relatively uncommon to have that happening when we have, the active plasmacytic inflammation in the endometrium. So our final sign-out diagnosis for our incident case was chronic endometritis, characterized by the presence of CD138 plasma cells within the endometrial stroma. And we've talked about some of the caveats associated with that. So hopefully that'll give you a little guidance on when to look, what to look for, and how to find them most effectively. We hope you enjoyed that. And so until next time, thanks for joining us.